Good afternoon, everyone. I'm Dr. John Shrigley, the clinical lead for the Cancer Care Ontario Checklist Pathology Project and chair of the National Pathology Standards Committee for the Canadian Partnership Against Cancer. On behalf of Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists, I'd like to welcome everyone to today's educational session on the CAP checklist related to bone and soft tissue tumors, to begin by Dr. Dr Kandel. Introduce our speaker and we get underway formally, I'd like to take care of a few housekeeping items. First, today's presentation will be approximately 90 minutes in length and will include about 60 minutes of presentation time to be followed by about 30 minutes of questions and answers. The session is being recorded and will be made available to all participants via email links once the recording becomes available. Both the live presentation and the recorded presentation are eligible for CME credits upon completion and submission of an evaluation form available electronically. The information for accessing the evaluation form was provided in the notice for this session that had been previously distributed. Please note that CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the presentation date. The questions will remain available electronically for an undetermined period of time, but CME certificates will only be issued for 1 month. Please refer to the session notice for the exact deadline date. Please note that everyone's line has been automatically muted for today's presentation. Due to the large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you're having difficulties accessing the WebEx portion of the teleconference, please call the WebEx support line at 1-866-229-239. We invite you to submit questions at any time during the presentation using the chat feature. For instructions on how to use the WebEx chat window, please refer to the documentation previously distributed. Question and answer portion of the presentation. In order to avoid question collisions, I will pose the submitted questions on your behalf as long as time permits and in the order that they appear. In the window, please include your institution's name, the individual posing the question, and then finally the question. It's my pleasure to introduce Dr. Dr Kandel. Dr. Kandel is a clinician scientist and Chief of Pathology and Laboratory Medicine at Mount Sinai Hospital in Toronto. She's a professor in the Department of Lab Medicine and Pathobiology, appointed to the Department of Surgery, and a member of the Institute of Biomaterials and Biomedical Engineering at the University of Toronto. Director of the Bioengineering of Skeletal Diseases team, which includes a multidisciplinary group of investigators whose work focuses on regenerative medicine for musculoskeletal diseases. Her expertise is in the diagnosis of soft tissue and bone tumors. She's executive committee of the Sarcoma Site Group for the National Cancer Institute of Canada. She's published over 170 papers and book chapters. So the Canadian representative to the College of American Pathology Protocol Review Committee for Bone and Soft Tissue Tumors. With further ado, I'd like to turn the microphone over to Dr. Dr. Kandel. Rita?
Thank you very much. It's a great pleasure to be able to talk about the tumors that I love, soft tissue and bone tumors. So I just start off by disclosing that I have served as a content expert for GlaxoSmithKline, and that's it. John has addressed the issues on how to ask questions. Please remember to click on the chat function. So the objectives for this session is to familiarize you with the CAP checklist for both soft tissue and bone tumors. In addition, I'd like to help you develop an approach to handling as well as the diagnosis and grading of soft tissue and bone tumors so that you'll be more confident as you complete CAP checklists. There are a lot of similarities between the checklists for both sets of tumors, but I've decided to separate them out into soft tissue and to bone. I will actually start with the soft tissue and spend most of my time on soft tissue tumors because really that's the commonest type of tumor that we see. Please note that there is a checklist for both biopsies and resection specimens, and they are quite similar, so I'll only mention where they differ. So please note that these checklists are not for pediatric tumors. They're meant for both adolescent and adult soft tissue tumors. So, quite daunting, the diagnosis of soft tissue tumors. There are a number of reasons for this. Most importantly, there are 50 subtypes of soft tissue tumors, as you can see in this WHO classification list. And this really doesn't even include the variants that you can see within each subtype. So, for example, this is a morphological appearance of a well-differentiated liposarcoma from two different cases. The tumor shows large variation in the vacuolar size of the adipocytes. There's ATF, and lipoblasts are easily identified. In the second case, this variation in vacuolar size in the adipocytes is not obvious. Most of the abnormalities are confined to the fibrous septi, which are more cellular cells with some cellological atypia, and it can be difficult to identify lipoblasts in these tumors. It's difficult to diagnose these tumors. Then, it can have specific morphological features that engender a large differential diagnosis. And an example of just one such tumor, the small blue cell tumor. And this is a morphological appearance of one of these tumors, and the differential diagnosis could include sarcoma, rhabdomyosarcoma, small cell osteosarcoma, and several other entities. To definitively identify and diagnose this tumor requires ancillary methodology. The immunohistochemistry and molecular diagnostics is playing an increasing role in the accurate diagnosis of these tumors. So in this particular case, when we did our further ancillary testing, we were able to demonstrate that the tumor expressed quite extensively desmoglein, indicating that it was a rhabdomyosarcoma. During this workup, the two cells also expressed CD9. Really, this is a protein or epitope that you wouldn't expect to be expressed in this tumor. And that's the other problem of soft tissue sarcomas, that it's fairly common for them to express aberrant antigens and epitopes that make the diagnosis of these tumors purely on immunohistochemistry alone difficult. So clearly there are a number of reasons that it can be difficult to make this diagnosis. However, if the tumor is adequately sampled, you have a much better chance of being able to make the right diagnosis. And when I talk about adequately sampled, you have to have enough tissue available to allow you to assess the morphological features on H&E, and tissue to allow you to perform the ancillary tests where required, the tests being immunohistochemistry, molecular analysis, and in those rare occasions, even electron microscopy. So here about the necessity to snap freeze tissue, which clearly is a luxury that many centers can't afford. And really, that's not necessary for diagnostic purposes, but it's more for research purposes to do further investigations so that we can begin to understand these uncommon tumors better. So, if the treatment plan is based on the diagnosis of the tumor, what's the best modality to actually sample the tumor so they get sufficient tissue or cells to be able to make this diagnosis? Well, soft tumors are no different than any other tumor. Finding aspirate or biopsies are clearly the two options. I should note that although I've listed excisional biopsies, really this type of biopsy should really only be done in small superficial tumors, if at all. So, what modality? Well, a number of studies investigating this question But there's only been one study that has actually taken a series of tumors and compared all the modalities in the one set of tumors. So there were 57 cases, and they underwent sequential needle aspirate followed by a core biopsy followed by an open biopsy. And these tumors, the diagnosis was compared to the resection specimen. This is a study out of California, and they were able to show that open biopsies most reliably gave you sufficient amount of tissue to make the right classification of the tumor into benign versus malignant, and did it the most accurately. It seems that fine needle aspiration probably is less able to do that. So quick biopsy is the preferred modality for sampling these tumors. However, I would be remiss if I didn't emphasize that core biopsies are probably sufficient as well. We all know that the constraints under which we live provides pressures on the operating room availability. So there's a real push to obtain use in the imaging centers or in the physician's office, and that's a core biopsy. There are a number of studies that show that core biopsies, particularly if sufficient numbers of samples have been taken, and the literature suggests at least 4 samples, provide you with an ability to guide the treatment for the surgeon. Core biopsies in this particular study by Strauss in the Royal Marsden was able to show sufficient adequacy and accuracy using core biopsies. Core biopsies seem to fall down is in their ability to accurately type the tumor and also to grade these tumors. And really, it's not surprising given the fact that there is a very different setting of the tumor in core biopsy relative to a open incisional biopsy. And just as an example of that, this is of a myxoid liposarcoma. Large part of it was myxoid. However, in this case was biopsied and was diagnosed as a myxoid liposarcoma, but when it could be more extensively sampled, the very small component that was not sampled in the core biopsy, the round cell component, became available. So, in some biopsies for the diagnosis of sarcoma are adequate, but should be at least 4 samples or more, and to live with the possibility that may not get a definitive diagnosis and accurate grading of these tumors in the core biopsy. And particularly, the issue is more an upgrading, because it's very uncommon to downgrade a tumor. It's more common to upgrade grade 1 or 2 tumor to a higher grade. Biopsy clearly, obviously, is better than core, but core is sufficient. And I think most people in the field feel that fine needle aspirate is not the optimal way to diagnose these tumors. So the diagnosis has been made, the surgeon goes in, takes out the tumor, and you receive the specimen. There's a lot of information that can be obtained from the gross specimen, so it's very important that it handled appropriately as well. The section specimen will allow you to confirm the diagnosis and grade when it was made preoperatively. It also allows you to determine other prognostic factors, such as the size of the tumor and the depth of the tumor, whether it's superficial or, in this case, deep, and also the adequacy of the margins. And that's very important because that actually helps direct treatment. Because if there is residual microscopic tumor, the surgeon then has to decide whether they're going to go back and excise the surgical bed, or perhaps decide to give radiotherapy to this tumor. So there's a lot of information that can be gleaned from the surgical resection specimen. And to get that information, it's critical that the specimen is oriented by the surgeon. You have to hang tough and train the surgeon to orient the specimen for you. Our ability is to ink those margins so that we can be sure that we're adequately assessing the margins. In the growing of these specimens, you should give the overall specimen size. The tumor size clearly is extremely important, and the tumor size should be measured in all three dimensions. And that will allow you to determine the largest dimension, because it's the largest dimension that's predictive in terms of patient outcome. Measure the distance to all 6 margins, or 5 margins if there's skin. Also want to determine the depth of the tumor, whether it's deep or superficial, and the relationship of that tumor to fascia. These are all questions that the surgeon could ask and requires to help guide treatment, and also the percent of necrosis. In terms of specimen sampling, representation should be taken from all of the inked margins, and samples should be taken perpendicular, not false, but perpendicular to the resection margin, and that allows you to see clearly the resection margin, its relationship to the underlying tissue. Current recommendation is to sample the tumor extensively, 1 section per centimeter, up to about 12 sections. And a number can be increased if tumor is polymorphous or has areas that you're more concerned about, and which you should take as many sections as you deem necessary. We recommend taking 1 sample from an area of necrosis, because necrosis in soft tissue tumors are notoriously overestimated. And we often misrepresent myxoid change for necrosis, and if you're worried about whether it's necrotic or not, just sample it. Samples that should be taken, if the tumor is close to fascia, you want to sample that interface to determine if the fascia is invaded by the tumor. The classical way of handling these tumors, and if you do all of those parameters, then you will have all the information that you need for a checklist. And it's because the checklist has features that are for the surgeon for treatment and prognostic for the patient. So now I'm going to run through the checklist and point out some pertinent points. The biopsy checklist for procedure is clear-cut. I tend to use the resection checklist when there's been an excisional biopsy, because it has the margins as part of it, but it's your choice, whatever you prefer to do. In the resection specimen checklist, clearly the options are quite different. And these decisions as to what you check off is based on your pathological evaluation of the tumor and not what the surgeon tells you. So for an interlesional resection, clearly there is either residual growth or microscopic tumor left behind. Marginal resection, the tumor with its capsule, if it's present, has been excised with a very small amount of normal tissue. For a resection, there's a normal tissue, and the resection is usually confined to 1 compartment. A muscle compartment is defined as the group of muscles bounded by the fascia. And there's 4 in the thigh and 3 in the arm. So they're defined The radical resection is one that involves removal of the entire compartment or a segment of bone with the tumor. So there's definitions for all of these tumors, but sometimes the classification can be a bit subjective. This is an example. This is a tumor that's been resected with a cuff of normal muscle. Clearly, there's one area here where there is very little normal tissue, and the tumor would be considered a marginal. How do you classify it? Clearly, this is the area that's important for the surgeon. This is how I classify it, as a marginal resection. Obviously, straightforward. The tumor size, then straightforward because you've measured the tumor in 3 dimensions. Please note, you only have to give the greatest dimension, and that's because the greatest dimension is what is predictive of prognosis. Whether you provide the additional dimensions is your choice. In your gross description, not very critical. Wonder how do you determine tumor size from a biopsy specimen? The expectation is that information for biopsies is determined from the imaging if it's available. And that's why there's a category of cannot be determined. So situations where you won't be able to have access to imaging and you won't know the tumor size. I recommend that in the comment section you might want to state the date from which image you took measurements, because clearly tumor can grow over time and that might be confusing going forward. Not obligatory, no. The next category to be evaluated is the macroscopic extent of the tumor. That allows you to indicate whether the tumor is superficial, deep, or a combination of that, or a combination of both of those. And that you can select every one that applies to that particular tumor. And clearly, whether a tumor is superficial or deep is important prognostically, but it also can influence your diagnosis. For example, a smooth muscle tumor confined to the dermis may not be considered a leiomyosarcoma, and there are some who are arguing for that now. You've got a tumor. It starts in the subcutaneous tissue, extends through the fascia into the muscle. This is how you would check off the checklist. To check everything to indicate the extent of the tumor. In terms of biopsy, this parameter has to be obtained from the imaging if it's possible. The biological type of the tumor is the next category, and that's based on the 2002 World Health Organization classification, of which there are 50 subtypes, at least 50 subtypes. So there's a lot to go through. And really, I can't show examples of all of these different tumors because of the time constraints. But remember, if you don't have enough tissue to make a diagnosis, there is a category cannot be determined in the checklist. The next two parameters are those of mitotic rate and necrosis. And these two are evaluated to help in the grading of these tumors. And so I'm going to talk a bit more of those in the context of the grading. Histological grading in soft tissue tumors is very important because it turns out that histological grade is the most important prognostic factor for patients with soft tissue sarcomas. Other factors such as depth and size are important, but grade is particularly important. Tips about grading. Grading can only be done on untreated primary soft tissue sarcomas. I don't have to explain why for the untreated, but we never grade metastatic sarcomas. And to emphasize that grading is performed only when you have sufficient tissue which you hope is representative of the tumor. Also, grading is not applicable to all types of tumors, angiosarcomas, clear cell sarcomas, for example, because it's not been found to be predictive of outcomes. So we don't grade those tumors. Sarcoma grading is an area unto itself, and the first grading system was described in the late 1970s, and a number of grading systems were developed, which immediately tells you that there are some problems with all of the grading systems. And that is likely because there's some subjectivity to these systems. Two systems that ended up being most commonly utilized was the NCI and the French Federation of the Cancer Centers Sarcoma Group, which for sake, I'm now going to refer to the French system, the FNCLCC. These two systems were compared in a study in the late 90s in 10 extremity sarcomas. And although there wasn't a lot of difference between these two grading systems, it showed that the French system was a discriminator of grade 1 tumors and a better predictor of outcome for grade 3 tumors. So the system is the one that won out, and that system that is recommended by CAP for grading soft tissue tumors, and is also utilized in the AJCC groupings as well. So soft tissue tumors is some discrepancies, and again, because as you'll see, there's some subjectivity to this grading. But just to get to you that there have been at least 3 studies showing that there can be discrepancies of up to 25% between pathologists in grading of these tumors. So please get upset if a consult case comes back with a different grade, the one you might have rendered. The French system is a 3-grade system, and it's based on tumor differentiation, the number of mitoses, and the extent of necrosis. So differentiation. Tumor differentiation. You can ascribe 3 points maximum to tumor differentiation. And the definition for is considered 1 point, 2 points, or 3 points. 1 point is a sarcoma that closely resembles normal adult mesenchymal tissue, such as a well-differentiated liposarcoma, as you can see here. Score 2 or 2 points is a sarcoma for which the histological typing is certain, and that would be a myxofibrosarcoma, which you can see here. And 3 points for those undifferentiated tumors, which could really be almost anything. And to help you along, the French system provides you with a table in which they list 21 tumors and ascribe a differentiation score to these different tumors. So I'm thinking that the WHO classification actually has 50 subtypes, but there's only 21 on this list. What's going on? Well, those tumors that should be graded and are not in this category, then you need to use these definitions to determine which grade, which score to give these tumors. A little bit of subjectivity in the assessment of the tumor differentiation score, which probably contributes to discrepancy between pathologists. The second feature that is evaluated is that of the number of mitoses. And this is a hotspot type of approach where you look at the tissue, find a spot where there is proliferation. From that spot, measure, in 10 successive fields, which you hope we hope is non-necrotic and has little or no fibrosis, at 40 times magnification. Now, 10 successive fields, but if you read the original description of the French system, they measured an area of 1.7 millimeters squared in developing that grading system. So if your objective diameter area is not that of 0.17 millimeters squared, then you need to count the appropriate number of fields that will give you 1.7 millimeters squared area. Now, on the microscope, that's 6 fields. So that's 6 fields when I'm determining mitoses. You count up the number of mitoses, and you can get, again, a total of 3 points, ranging on the number of mitoses in that 1.7 millimeter squared area. Caveat, peculiar to soft tissue tumors is the fact that sometimes you can get an infiltration of lymphocytes, and the lymphocytes can become flattened and elongated and look like a mitotic figure. This is a mitotic figure in contrast, and when you see them side by side, you can appreciate their difference. But when you're counting mitoses, it may be more difficult. Just be cognizant of the fact that the lymphocytes in soft tissue tumors can do this and be less likely to upscore the number of mitoses. The third is that of necrosis, and it's evaluated purely on the histology sections. Here you can get a score of up to 2, and it's really very easy. 1 point if there's less than 50% tumor necrosis on all the sections, or 2 points if there's more than 50%. To determine the grade, you find the scores from all 3 of the criteria, a total of 8 points, and then grade 1 tumors have a score of either 2 or 3, whereas grade 3 tumors can have a score of between 6 and 8. Relatively straightforward. You'll note that in the grading parameter, you'll find section ungraded sarcoma, and that is related to the sarcomas that are not graded. So that category to check off when you have one of these tumors. So the French system is not predictive outcome for these tumors, and for that reason, we don't grade them. Alveolar soft part, clear cell, malignant peripheral nerve sheath tumors, epithelioid sarcomas, specific types of rhabdos, angiosarcoma, and extraskeletal myxoid chondrosarcomas. So these tumors are not graded and checked off as ungraded tumors in the checklist. The next parameter is that of the margins of the specimen. Clear positive margin, negative margin is straightforward. When the margins are negative, the surgeons like to know what the closest margin is and where it's located, hence their involvement in orienting the specimen. The other information that's on the checklist is indicating which margins are less than 2 centimeters. And there are some studies and some surgeons who act on margins that are less than 2 centimeters in width. And so for that reason, we need to provide them with information of tumors which have margins that are less than 2 centimeters. Lymph node invasion is an optional parameter and does not have to be completed. A section of additional pathological findings, and this is the place where I put the fact that there is multiple tumors in that particular specimen. That occurs very, very rarely, but it does happen on occasion, where you might have two tumors separated by 2 centimeters of soft tissue. And this is where I would place it. Studies, as I've alluded to, are a very important part of the diagnosis of soft tissue tumors. So they get their own category and documentation of what was done. I'm just going to briefly talk about this, given the importance of these ancillary studies. I've already alluded to the importance of immunohistochemistry, but I'd like to talk very briefly on the importance of molecular diagnostics in being able to make an accurate diagnosis of a soft tissue tumor. I have put here a collage of tumors which have been shown definitively to be synovial sarcoma. And I'm showing these to you just to demonstrate how diverse the morphology of these tumors can be, ranging from the classical biphasic synovial sarcoma. Although I must admit, if the needle went in here, you might be wondering about a metastatic carcinoma. A tumor that looks very, very neural. A tumor that you wouldn't even really think about synovial sarcoma in the differential. Of course, you can do immunostaining on these tumors, and they may or may not be positive for keratin or EMA, and it can be quite problematic, particularly if you've got a tumor that's keratin positive and S100 protein positive, which can occur in synovial sarcomas. It turns out that there's a subset of soft tissue tumors, less than 20% of these tumors, which have translocations that we can utilize to help us make a diagnosis in these difficult cases. I'm going to briefly review with you for chromosomal translocation. I'm using the synovial sarcoma X18 translocation as an example. So what happens is you have an X chromosome and a chromosome 18. A portion of the DNA breaks away in each one of these chromosomes. There is a reciprocal translocation of these components of DNA, as you can see here. So the X chromosome has some 18, and the 18 chromosome has some X chromosome, and it's considered a translocation. So you have a chromosome with 2 different components of DNA. This chromosome can then undergo transcription and give rise to RNA, which has components of the normal 18 and the components of X chromosome. And this mRNA is considered a fusion product or fusion RNA. And you detect the chromosomal translocation, or you can detect this fusion transcript. And there is some thought that it's the alterations around these break points that are leading to some of the changes that are occurring in these tumors as part of this process. If you're looking for the fusion product, the mRNA, you can extract the RNA from the tissue. You can amplify the reverse transcript, then amplify the product and run on a gel and identify the fusion product. As you can see here on this gel, we do a number of controls to make sure that everything's worked well. Ultimately, you can detect the fusion in the chromosome by break-apart FISH. And this entails using a dual-colored or dual probes, the chromosome distal and proximal to the breakpoint. So if there is an intact chromosome 18, the two colors are close together. But if there is a translocation, the two colors are separated, the distance related to the different locations on the chromosome. Details of this are not important. What is important to note is that both of these studies can be done on paraffin-embedded tissue. So you don't need specially processed tissue to do these types of analysis. So there's some question about the tumor histology, immunos not helping you, then molecular diagnostics are the next step. But I do want to mention that although we tend to think of these translocations as discrete for each tumor type, and for the most part they are, there are occasions when a translocation can be seen in more than one type. And I'll show you an example of this. In of a melanoma versus a clear cell sarcoma, all the immunos the same. You go ahead and you do the molecular diagnostics and you demonstrate the presence of EWS R1ATF fusion product that arises from the 1222 translocation. We detect in about 75% of clear cell sarcomas. It turns out that this fusion transcript is also present in angiomatoid fibrous histiocytomas. So clearly, looking at tumor is a very much part of the assessment of these tumors. That it's not to just say that we're going to go forward and just do molecular diagnostics for those sets of tumors in which we know the molecular abnormalities. Next parameter is that of the pathological staging, the TNM groupings. And there's really no trick to this. I just want to point out that the difference between a T1 and a T2 tumor is a tumor that's less than 5 centimeters. That's a T1. And if the tumor is greater than 5 centimeters, it's a T2. And that's because that relationship to prognostic indications, tumors less than 5 centimeters seem to do better than those that are bigger. And then whether a tumor is A or B depends on whether it's superficial or deep. And if the tumor is superficial and deep, it's a B. Lymph mets in soft tissue sarcomas are very rare. They occur, if they occur, they more commonly occur in entities like clear cell sarcomas. So this generally is not something that is important to soft tissue tumors, and then metastases are clearly obvious. The other feature in soft tissue tumors is the effect of treatment on these tumors. So for the most part, the tumor either receives no therapy or can receive radiotherapy. And chemotherapy is rarely used in these tumors, although it's used in certain subtypes. And this is a good reminder to confirm whether this tumor has been treated or not, because obviously that would affect your grading in that you wouldn't have graded it. There is then a category of treatment effect, and that really is so just to describe it, this treatment effect is defined as the percentage of viable tumor, and this viable tumor in the entire tumor. You estimate from the necrosis as well as the reparative changes. So there has been a sufficient time between the tumor resection, the tumor could have undergone necrosis and repair, and in that setting, you might underestimate the treatment effect, and so therefore necrosis and reparative changes are all part of that determination of percentage of tumor that's viable. And this is done on the tissue sections and the growth, and so you have to be mindful of where you've taken your sections. And please remember that estimation of necrosis and the growth can be problematic, and if there's any question, you should sample the area. And it's been recommended that if there's extensive necrosis in the growth, that you might want to just use that number if it makes it easier. The parameter is indicated on the checklist, but there's no hard evidence yet that treatment effect responsiveness is a predictor of outcome, as it is for bone tumors. Of course, there's always room for us to comment. That's the soft tissue tumor checklist. I'm going to go over the bone tumor checklist much more quickly and just look at the differences between it and the soft tissue tumor checklist. Just to mention again, there's a biopsy checklist and a resection specimen checklist, and my guess is that if you're going to add any, it's most likely to be the biopsy checklist. So the issues about the diagnosis of bone tumors is no different than soft tissue tumors, with one important caveat. It's so very important to correlate the histological features with the imaging features of the tumor. I can't tell you how many times I've been influenced by the imaging features in my evaluation of the tumor. So it's really very important. I emphasize that strongly enough. Again, bone involvement, clear cut. The procedures are similar to soft tissue tumors, but instead of open biopsies, they're called curettages in the bone setting. In the resection specimen list, the options are similar. The definitions are similar. As in the soft tissue, again, intralesional, you're leaving residual tumor, marginal, small amount of adjacent tissue. The segmental wide is defined by adjacent normal bone, and if the entire bone or multiple muscle compartments with the bone, it's a radical resection. An amputation would be other. The two sites, I must admit, I find challenging, and I find that having this figure very helpful in trying to remind me the location of the different parts of the bone that you have checked off on this checklist. So it becomes much easier. The other peculiarity of bone tumors is that the tumors can occur on the surface, and that's why you have this designation of surface for a site. Dimensions, again, just like soft tissue tumors, the greatest dimension is all that you have to record. The additional dimensions, the other two dimensions, are not obligatory. Bone tumors are interesting in that they can, on occasion, have skip lesions or be multifocal. There's a site there for you to indicate that. And again, just like the soft tissue tumors, the tumor size biopsies checklist have to be determined from the imaging studies. And again, you might want to document the date if you can. The histological type is also based on the World Health Organization classification, which I'm showing here. And clearly all sorts of the soft tissue type tumors can occur in bone. But commonest bone tumors are clearly metastatic malignancies, then followed by osteosarcoma, chondrosarcoma, and Ewing's sarcoma. So just to briefly show you some histology, to be able to make a diagnosis of osteosarcoma, we like to see osteoid production by tumor cells. The spindle cell tumors that occur in soft tissue have exactly the same morphology in bone. Fibrosarcoma is identical in bone and soft tissue. A malignant giant cell tumor, for example, you might see normal giant cell merging with clearly a tumor that is acquiring malignant characteristics. And then Ewing sarcoma, which is a small cell tumor, and that has no matrix production. Mitotic rate can be determined, and you'll notice that that is optional. Fibrosis, again, another variable that needs to be determined. The histological grade, which is than the grading system used for soft tissue tumors, in that there's not one grading system that fits all. So the French system has no corollary in bone tumors. Except for the soft tissue type sarcomas that occur in bone, fibrosarcoma, myosarcoma, you grade using the French system. The other tumors that are graded based really essentially differently in that bone tumors are graded differently from chondrosarcomas and Ewing sarcomas. So Ewing sarcomas are always grade 3, adenomatomas always grade 1. Osteosarcomas are graded on their cellularity and their resemblance to normal bone, as well as atypia, and chondrosarcomas are entirely different. To show you what I'm talking about, this is a histological appearance of a low-grade osteosarcoma. You can see the well-formed trabeculi. The strut is a little atypical, but not very cellular. There's not much in the way of atypia. The bone trabeculi are obviously very cellular. It's a grade 1 osteosarcoma. Closer resemblance to bone. Closer, not close, but some characteristics. In contrast, a high-grade or grade 3 osteosarcoma is cellular, and it can make variable amounts of osteoid. In this particular case, there's a large amount of osteoid, but the tumor is cellular, and there is pleomorphism in these cells. This would be a high-grade or grade 3 osteosarcoma. Sarcomas, on the other hand, are based on cellularity of the matrix, atypia, and the atypia is nuclear, and so we test that, the nuclear size, and the presence of binucleate cells. Necrosis is also another parameter that we will evaluate. Sometimes it can be difficult to differentiate between an enchondroma and a grade 1 chondrosarcoma. So if you see the tumor percolating between pre-existing bone trabeculi, and in this case completely surrounding it, it's more likely to be a chondrosarcoma than an enchondroma. Clearly, in some chondrosarcomas, there's no matrix at all. This is a mesenchymal chondrosarcoma, and that's considered a high-grade tumor. So grading of bone tumors is a lot more complicated than soft tissue tumors. Molecular invasion, again, an optional parameter to complete on this checklist. And in this section of additional pathological findings, this would be the site where you might include the presence of Paget's disease or a bone infarct, entities which we know can be associated with the development of a bone sarcoma. Advanced studies is also a category in the checklist, and these can be done, although they are not done as commonly in bone tumors as they are in soft tissue tumors, just because of the relative infrequency of the soft tissue type sarcomas in bone. But if that is in the differential, you really hopefully will have put aside some tissue that you've processed without decalcification. And we're not always lucky in that respect, but you have a better chance of accomplishing it if you're thinking about it. Not always lucky, though. And interestingly, in the bone tumor checklist, there is a category for radiographic findings. And this is really just to emphasize the importance of correlating the histology with the radiology. And this must be documented if it's available in the checklist. And I just very briefly wanted to show you how we handle bone resection specimens, just for your interest, and again to help fill out the checklist. And I'm not really talk very much about the bone resection checklist. So this is a digital femur, a proximal tibia that has been resected for a chondrosarcoma. You can see the patellar groove here. This is the tissue around it, so it's a segmental wide resection. There's a tumor on the cut surface. We then serially section these tumors with the bandsaw and take X-ray images of the sections. After, I should mention that we cut off the margins before we actually section the tumors. Okay, so we take X-ray images of the tumor to determine which lab that we want to process for histology. And we put aside the margins, select the lab, one or two, depending on what you decide upon. We measure our sections, and then we submit that for decalcification. This processing, we determine the size of the tumor, again, in 3 dimensions, and get the various measurements that you require. And this is to demonstrate how specimen X-rays can give you valuable information. And in this here, you can see that there is some disruption of the cortical bone, which has been really very thinned. And so it really to evaluate the tumor and where to take the sections from. So our sections described our tumor, and in these big resection specimens, you have to stage them. And in contrast to soft tissue tumors, where the cutoff is 5 centimeters, for big tumors, for bone tumors, it's 8 centimeters is the cutoff. And indicate here for skip lesions. Again, lymph node metastases are very uncommon in these tumors. In these bone tumors, we assess the effect of treatment. That is particularly important because chemotherapy is often given to many of these tumors, and determining treatment effect is an important prognostic factor, and we even direct what chemotherapy the patient may subsequently get. In contrast to soft tissue tumors, where you document the amount of viable tumor, here you document the amount of necrotic tumor. And so is a very brief overview of the CAP checklist for bone and soft tissue tumors, description how to handle and grade these tumors. And thank you for your attention, and I'm glad to answer any questions.
Very much, Rita. We don't see any questions on the chat window yet, so I just had a general question for you, since you're also the representative for the CAP Soft Tissue Protocol Review Committee. Are there any areas of improvement for the soft tissue or bone checklist as it exists now that you will be recommending on a go-forward basis as we evolve these checklists over the next year or two?
Absolutely. In particular, some of the descriptors for the procedures can be confusing. There's redundancy in the CAP checklist, and so getting rid of some of those will make complete the list more time useful, time efficient. So some of the features, again, the issues related to the fact that the WHO classification of tumors is much greater than the French Federation is something that needs to be dealt with as well.
Thank you very much. We don't have any questions at all in the chat window, and I guess hope we have one just coming up right now, and this one's from Dr. Leanne Widjanarko in Sudbury. How thin do you section the bone section? How thin are your sections for bone resections of bone tumors?
5 millimeters.
Yes. Okay. Thank you. I don't see anything else, so I'm going to make a few closing remarks now. On behalf of Cancer Care Ontario, the Partnership Against Cancer, and the Canadian Association of Pathologists, I'd really like to thank you, Rita, for a truly comprehensive, informative, and very clear presentation today. This is our third session in the third series of the CAP checklist presentations, and we would welcome your comments and suggestions for ways to improve the sessions to be more informative and relevant to your practice. Please include your feedback and suggestions as part of your completed online evaluation. WebEx recordings of this presentation become available, made available for wide distribution via links by Cancer Care Ontario, the Partnership, and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. As a reminder, both the live and recorded presentations are eligible for CME credits. In order to receive these credits for attending or viewing the educational sessions, you must complete an evaluation form for each session accessed or viewed in its entirety. The link to the web-based survey has been included in the session notices previously distributed. Please note once again that CME certificates for each session will only be issued for 1 month from the presentation date. The sessions will remain available electronically for an undetermined period of time, but the CME certificates will only be issued for 1 month. Please refer to your session notice for the exact deadline date. Next, as an announcement, our next session in the current series is on February the 1st. And it will be given by Dr. George Jansen from Ottawa, and this will relate to the checklist for brain and spinal cord tumors. Thank you very much. The session is completed.